Hey, it's Dr. Amanda with StraightSmile Solutions, StraightSmileSolutions.com, and today we're going to talk a little bit more about compromise cases, e.g., taking cases that you can't make perfect. We all, once you start doing more ortho, get patients that come in, they're like, look, I know I have to have jaw surgery to make this perfect, but can you just make it look better? So I wanted to kind of dip into that a little bit, and I have kind of a unique viewpoint because, I am an actual orthodontist, almost 20 years of experience. I've seen, done, been a part of tens of thousands of cases at least, if not more, in one way or another. And I've also been part of some expert witness situations, situations with dental boards, not against me, but against other people, where perhaps my advice was given. I can't really speak to those. I really find it fascinating to tap into liability insurance companies, and a lot of general dentists that are doing ortho really have no idea what kind of hot water they can get themselves into. Certainly orthodontists have more of an idea because we've all dealt with second opinions and cleaning up someone else's messes, and we know what the insurance company can say, and we know what the dental board can say if you misstep. So let's talk about compromise cases. First of all, you need to have compromised release form. Now I have one in my store that you can purchase. It's $20. It's free for our actual VIP or concierge clients. They get unlimited access to our database of forms. It's just a template. You can use it. I'm not an attorney, so you can run it by your attorney. You can use it just as a jump start, at least in terms of the dental terms. But you got to have that. That's the first thing you got to do. You do not take compromised cases without compromised release form. That's standard because that's going to help protect you. But in essence, if you're not going to make a case perfect, then you need to be explaining in verbally, but in writing, and also grabbing a signature for that patient as to the risks, benefits, and alternatives of this compromised treatment plan in comparison to an ideal treatment plan. Now, you can't just say, okay, I'll do it, unless you have all of those dots, everything checked, because unless you cover yourself, CYA, cover your, you are leaving yourself at risk if there's ever a complaint. And, maybe it's just a refund, but maybe it's also getting your license taken away. So it could be a very expensive malpractice suit. It happens. And these type of cases are dangerous. I'm just letting you know. So I'm going to talk about class 3 cases right now. And then I'm going to do a subsequent video right after this that I'll post. It probably will be back to back about overjet. So let's talk about this. First of all, class 3 cases. First thing I'm going to do is I'm going to find out the age of the patient and where they are in their pubertal growth spurt. Obviously, if the patient is over age 20, they're an adult. But if they're between the ages of, I would say 6 and 16 or 18 even, there's a potential for growth still. So you need to call a spade, and you need to treat it based on what's right. If the patient still has growth potential, you need to be factoring that in. That would be standard of care. And I don't think doing compromised on kids is standard of care. You're gonna have a hard time holding that one up because it's not standard of care. On an adult over age 18, okay, you can make your own decisions. I'm fine with that. I personally don't do compromised on kids. That's where I put my foot in the ground saying, nope, go to someone else, sorry. Because I don't feel like kids can make their own decisions for that. Let's say this is an adult. If it's a kid, I'm going to try to do whatever I can to encourage the growth and fix it the right way. There's face masks, there's all kind of stuff you can do. Okay, but we won't get into that because I have a zillion videos on that already. Let's talk about the adult. Let's say it's an adult. Adult is over 18, clearly not growing. What do we do now? Next step is going to be, often in class 3 cases like this is actually not the bite. This is the CRCO shift. They have an interference and they shift to a more comfortable place. So you need to try to get the actual bite. This is not the bite. Often when you see the midlines off like this, it's not the bite. So I have a good video on how to understand a CRCO shift, how to detect it. If you want it, I can send it to you. If not, if you go into my videos and just look up CR or CO, it should pop up. It's from about a year or 2 ago. It's an old video, but it's good. You'll want to find the actual CR and take photos in that, even if it's like a funky bite with an interference, and then that's your starting point. So it may not be as bad as you think, right? So that would be my first step with this. Once you know exactly and then where it is, of course, you're going to have to get a Ceph. You have to get a Ceph. So if you don't have access to a Ceph machine or you don't know how to get access from somewhere, you should have no business taking this case. Don't take it. You need a baseline Ceph. get baseline ceph numbers. You need to know where the deficiency is or where the excess is. Is it a big mandible? Is it a deficient maxilla? Or is it a combination of the two? Then, easiest way, honestly, to play with it for me is, I have a pretty good idea when I look at a case based on what I've done in my eyeballs and stuff, but I always like to scan it and put it in Invisalign. You can always do these cases in Invisalign if they're doable, but they've got great software. And it's a great way to mock it up. Yes, maybe you want to do braces, but it's a great way to simulate the movements, and everything, as far as I'm concerned, everything can be done in Invisalign. You just need to know how to do it. So that's what I do. I throw it in Invisalign and I play around with it. Obviously, this one is missing a lateral, it's got a peg lateral here. It's probably a CRCO shift. It's probably not as hard as you think, because if you consolidated the space, made space for an implant here, retracted this, get it into the CR, it actually may not be that hard as you think. Maybe you can't fix the posterior crossbite, but I'm pretty sure you could fix the anterior fully as long as you're willing to get an implant here. So sometimes a compromise might be pulling out some teeth, either an incisor or 2 lower bis. Not really my preference normally, but it might be an option for sure. Or opening up spaces around the lateral incisors if they're pegs. That'll help out a lot too, right? So yeah, pretty much that's my spiel for class 3 cases. You need to be careful. You need to treat it the right way. You need to give options. You need to explain risk, benefits, and alternatives. The patient needs to be fully educated. All that needs to be put into a document along with the compromise paperwork that they need to sign. And again, if you don't understand what perfect is, send them to an orthodontist just for a second opinion. They need to know what perfect can be. They need to know that they can get that. And often one of the biggest mistakes I've seen is that if you don't do that and you don't encourage them to do that, you can't force them to do it, but you can encourage it. You get them to a point where you fix them to a compromise point, maybe by taking out some teeth, and then they realize later, hey, I could have done this jaw surgery, and oops, it would have been fully covered by insurance because I'm having issues with my jaw joints or my airway or my ability to eat or speak, and orthodontists and oral surgeons together, they can do magical things if the patient needs it for health reasons. Often it can be fully covered, and it transforms their face and their airway and their functionality and their lifespan. And by you doing that compromise case, I know I'm pushing it a little bit, but this is true. By you just jumping to conclusions that this is best for the patient and this is what the patient wants because this is what the patient's asking for, but not fully explaining the risk, benefits, and alternatives, you are putting this patient at a possibly shorter lifespan and a disadvantage. You're damaging this patient. You didn't fully explain the risk, benefits, and alternatives. So if you can't explain it, then you probably shouldn't be doing the compromise case. If you can't explain it, or you don't strongly encourage them to go get that orthodontic consult and find out if that's what they want. If they go and they get all the information and they still are adamant, I understand, I saw the ortho workup, I saw the oral surgery workup, I know what my copay is, I still don't want to do it, fine. But I need to be able to sleep well at night. I need to be able to know that what I'm doing is not going to damage the patient. And sometimes when you do a compromise on these, you put them at a very unhealthy position for their teeth, their bite, and you're actually doing more. Yes, maybe they like the way it looks better, but you're doing more damage to their airway, their jaw joints, their bite, the stability of their teeth. It's going to cause breakdown, abfractions, attrition. If and when there was a complaint 10 years down the road, you're going to lose in court. So that's why I want you not to be pressured by these patients. So hopefully this was inspiring. All right, thanks so much.